Welcome to this episode on All Things LOCS, where we talk about leadership, operation, culture, and strategy. And today we have a phenomenal guest for you. We have Dr. Julie Siemers. She is a TEDx speaker, author of Surviving Your Hospital Stay, and she brings over 45 years of nursing experience across critical care, education, and executive leadership. So she's a champion for patient safety and healthcare transformation. She holds a doctorate of nursing practice from Touro University, where her research centered on reducing medical harm and driving meaningful reform. Dr. Julie, thank you so much for joining us today.
Thank you for having me. Yeah. It's an honor.
So we were talking a little bit offline, and when my ears perked up when we were saying healthcare transformation, but also patient safety. Now, to everyday people, like, what does that actually mean? Because I feel like that can mean a ton of different things.
Yeah, so I approach it from the healthcare aspect of acute care, because that's, again, where most of the harm occurs. And harm is never intentional, or rarely intentional, I should say. But it really, if we peel it back and do a root cause analysis, is because of systems errors. So when we break it down to patient safety, we look at buckets of medication mistakes or errors. That's the biggest one. And honestly, it's so crazy because that seems to me an easy one that we can fix or should have been able to fix. Diagnostic errors and communication is really been identified as the number one patient safety concern, because 70%, according to the Joint Commission, 70% of patient harm ties back to communication errors. Now, that can be between healthcare providers themselves, doctor to doctor, doctor to nurse, but then we have to have the family in there too, the family and patients of breakdown in communications between them and the healthcare team.
That is a crazy number. 70% is it could be traced to simple miscommunication. It could be a system miscommunication. It could be just a belly to belly miscommunication. That there's a lot of harm happening in our healthcare system just because of things talking to each other the right way or wrong way.
Yeah. Or forgetting information to share between each other. That's another part of that too.
Yeah, I was going to ask too, like, for the person who doesn't know, what, on a grand scale of how many errors are actually made per year? And then, we talk about preventable, it's just not even harm, but preventable deaths. So when we're talking about errors, what are we actually talking about? And then how does that translate into, unfortunately, people passing away due to simple mistakes that were avoidable?
Yeah, there was a big study done back in 2023, layered on many other studies that have been done in the past. And they say in the Medicare age category, so older patients, 1 in 4 patients suffer some kind of harm. And if we take that age group out to all patients, so including younger patients and even children, it's about 1 in 10. Those are pretty horrific odds. I mean, are you in Vegas? Is that what I remember?
Yes.
Yeah.
You wouldn't gamble on those odds, would you?
No, especially not one's life. No.
Exactly. And so there's other research out there that says the number of patients that actually die because of medical mistakes or errors is anywhere from 250,000 to 400,000 per year.
That's crazy.
Now, if we look at even 250,000, we break it up over 365 days, that's 684 patients on the lower side of patients that are harmed every single day. That's just horrific, right?
Yeah. And then that's, you're just talking, like, again, you're focusing on the acute inpatient hospital sort of setting, but then that, how much of that is even taken into account for just general doctors, GPs, orthopedic doctors, you kind of add that layer in, and then you really think of how much of an issue really is this. And then outside of, you mentioned communication being a big cause of that, right? So where do you see that improving, or where do you think we need to actually get that better, and how do we simply do that?
Yeah, this is the idea of my TEDx talk, was to communicate to both sides of the parties involved, the healthcare providers and the patients and their families, and we each have to do our part. And I think what we need to do is build that bridge that we don't currently have. So patients and families need to be informed, educated, and empowered. And then healthcare providers need to listen. I know we talk about medical gaslighting, but it's a real thing. You know, somebody described it to me the other day. Oh, is that when the doctor just pats me on the head and said, dear, we'll take care of it.
Yeah.
Or you're fine. You don't really have a problem. So I think that's a great place to start is we've got to fix it from both ends.
Where do you see that actually on the provider side? Doctor, healthcare providers across the board, where do you see that actually becoming the beginning process for that? Or
Well, I
like
wish
in a
it would
perfect
start
world?
in school. Yeah, exactly. I wish it would start in school so they could understand that the family and patient really do have valuable information. They don't have a medical degree, but they have valuable information about their body. When they say something's not right, we need to listen. And I think a lot of healthcare providers fall back on what they learned in school and what's textbook, but they don't really listen enough to get the details to say, oh, well, if this and this and this, then maybe we're looking at something that just doesn't roll off my tongue the first time I hear. So we need to deeply listen. And unfortunately, our healthcare system is set up today where providers are so jammed for time
Yeah.
that they're just rushing through and they're not able to garner all the relevant information to make a priority decision.
So it very much sounds like it, just for me from an outsider and being a dad, it's like there's kind of two parts. I mean, one of them is that you just have a medical professional, you have a doctor that is just trying to do the best that they can with limited time because they're on back to backs, and you only have maybe a few minutes with somebody. So that's definitely sounds like it's a system scheduling thing. But on the flip side of it, too, you were mentioning communication. What do you suggest that doctors do kind of in those times? Like what kind of training would you advise them, books to read or anything like that, where it's like, this is a controllable skill set that you need to develop so you can listen better, you can communicate better?
I think even just starting with the basics, just don't fall back on your training, but really listen to what the patient has to say. And in that time crunch, that's where we need to educate patients and their families better too, to come in with, hey, here's a quick journal of what happened the last 3 days, which is why I'm here. My heart rate started at this, or my fever started at this, my pain started with this, and really help drive down to the really pertinent information that then the doctor can analyze quickly if the patient is bringing that relevant data to them to say, well, that makes a difference in what our plan of care.
We talk a lot about, and just in general business, a lot of and definitely in medicine, a lot of emotional intelligence. And obviously part of that, right, is being empathetic, and that really goes with listening. From a standpoint of the skill set, as you mentioned, like an ideal world, we would be teaching these things to students in college. But since we're not, I'm just curious to know, this is just plain old ignorance on my part, do you see continuing education courses coming out, like trainings that nurses, doctors, and other providers can actually start to, undergo to learn these? I mean, I know that's definitely part of your curriculum, which we want to dive into at some point, but like, what are you seeing on your end to actually educate them?
Yeah, I think it really, most settings, it's the leadership that sets the tone. And so if you have the CEO of a hospital, for example, that says, we want to be customer facing. Well, we are customer facing. Let's be customers and patient centric. And really, what does that mean? And it's going to take a team approach, as you said, with emotional intelligence. If a doctor is condescending to a nurse, somebody else who hears that's on the team saying, let's take a time out here. How can we solve this problem together? We have a hierarchy still in healthcare. And I think that makes it, for the patient end of it, it's intimidating to approach the healthcare providers. But on the healthcare providers end, it takes a little bit of humility to say, maybe I don't know. Let me try and find out. And so it's a shift in mindset that really the tone needs to be set from leaders.
What do you see as the biggest hindrance? And I just want to maybe even preface that with, I do see a lot of communication with medical doctors across the board where they discuss a lot about the need to feel perfect. And, obviously it's a little bit harder to do that from a standpoint of not harder to be perfect, but from the standpoint of the humility aspect, do you see that as a barrier, or do you see other stuff coming into play where maybe some medical professionals don't have that humility and they're not maybe willing to admit, hey, I don't know exactly what's going on here? And
Yeah, it's one thing I teach patients and their families. I would rather have a doctor tell me, I don't know, let's find out together. I mean, we're blessed to live now in this day and age of AI where patients and families can look up things. I mean, it's to me 10x Google, right? Or maybe 100x, because you can get some wonky answers from Google like all over the place. But with AI, you can really train it to say, these are my medications. This is my disease, chronic disease that I'm dealing with. The doctor just put me on this medication, and really use it to inform and educate yourself. And then I think we're better partners with the healthcare team. But, I think really doctors need to understand that it's okay not to have the answers, and you don't have to be perfect. I would tell my nursing students, the only dumb question is the one you don't ask. And so when we assume, that's when we can get ourselves in trouble.
It seems like with just most people in general, just as life goes on, people get, wiser, they've kind of get kicked around a little bit. And this can happen really in any industry, in any profession. But, I have a huge family of doctors from the Stanford, the USC, and it's like when they first got into medicine versus 20 years later, like their bedside manner, them as people, like they develop. Kind of describe like some of those differences of how new doctors going in and maybe some of the shortcomings that they're having that's actually affecting this. Cause I think there's more and more doctors that are retiring now more than ever.
Yeah, one of the things I see with residents, I mean, there's so many case studies with patient harm that's occurred because the resident doesn't reach out or ask the attending for advice, or maybe if they start out asking advice and then they just continue on trying to treat this patient who's become critically ill, that's a problem there too. And I try to, again, tell the patients and their families, yes, they're a medical doctor, they went to medical school, but they're still in training. So, it's understanding the limitations, but I think sometimes the residents may forget, I don't know it all and I don't have 10 years of experience yet, and I need to be humble enough to listen and to ask. And I'm not sure why our society paints that picture that you have to be perfect and you have to know it all, because there's more that I've learned that I've forgotten than I've learned. Did I say that right?
Yeah.
You know what I mean?
No, it makes total sense to us. Yeah. It's super wild because like even so even with something like that, like I'm kind of finding it to be like a quite human thing. Like it's a human approach where you are trying to develop and you're learning things in your ego, and sometimes it's an environmental conditioning. Where I see this a lot too is sometimes with attorneys, where one of the things that they're taught a lot is about positioning. That like you never want to position yourself in front of a client or with a foe that you don't know something, and because if that is projected or that's picked up upon, then that can be exploited and you can lose a client. And I wonder if there's some overlap or similarities with that when it comes to doctors, where like just because they don't know or they're unsure means that they're incompetent or a potential failure.
Yeah, certainly the potential for that. And I think it's going to be related, as you mentioned earlier, with personality, right? And that, pardon me, that mix of service and knowledge and trying to help, it's complicated, right?
Mm-hmm. I wonder too, like if they have a patient in front of them where they're just like, I'm in so much pain, I got this, and they're just like, they just want to give them an answer or give them something, even though they're not 100% sure it's actually the thing.
You bring up a really good point, because medical schools, heard this from a credible resource, are funded by big pharma. And so if we think as a consumer of medical care, if that was our physician training, is based on, okay, here's the disease, diverticulitis. Here's what we're going to do for diagnostics, and here's the medications we're going to give. So it gets into this path that boxes them into, I think, not being able to see the full picture sometimes, and not getting to the root cause of why is this patient having this problem. Again, we talked about this, the time crunch, makes it nearly impossible for them to dig into other factors that may be contributing to this disease process.
It's very interesting when you describe the process like that. I also think about not just the effect that it has on the patient, but the effect that it has on the other support staff, right? Maybe have support nurse, what have you, and some of the maybe conflict that they face. Even yesterday, I think I was reading there's an Instagram post. There's this doctor who is all natural, but I like sometimes reading the comments on I don't think I'm the only one. Where you go through comments, see what people have to say, especially as it relates to health and nutrition and wellness. And it was a nurse who commented about, it was the exact same thing you just described. Like the doctor likes to give medications, but then doesn't really talk to the patients about nutritional changes that they can make or dietary. And she was like, I'll give them some tips and maybe things to kind of do in conjunction. So I'm curious to know, especially on your, the nursing side of it too, how that creates some conflict for those employees who might be thinking, I think there's a better way. We don't need to maybe give as much medication, but I'm in disagreement with the doctor who's the person actually making the decision here.
Yeah, I think the best route in that situation and scenario is to say to the patient, here's some resources, because there's plenty out there now to support lifestyle changes, whether it be smoking cessation, whether it be, exercising, even just walking, that would maximize the health benefits. And I've known so many patients that have gotten off blood pressure medications or diabetes medications because they've changed their lifestyle. And I can't remember the statistics, but it's about 20% of doctors even have a nutrition course in their medical school training. I mean, that right there tells you that we're not set up for healthcare. This is disease care. We've got to flip it for the patients and their families to, again, take back their power by being informed and educated, and to not be a passive recipient of healthcare, but be active. Do you want to be on that medication the rest of your life? Because most of them have side effects. Or would you rather feel better? Right?
Oh, absolutely. So it's interesting because you could very well have a doctor listen to this and they're like, you know what? I do not take enough time with my patients. I am doing a little bit more guesswork. I do realize that a lot of my training is kind of pharma leaning and I need to kind of move in another direction. One of the things that you mentioned, especially around leadership, because, as the leader of the organization, like the lead doctor, there's a certain click that has to happen where like, okay, we're going to start doing this a different way. We're going to start shifting our mindset, shifting our system, shifting our approach. If you work with a doctor like that, what's some advice you give them that now they say, hey, we got to make some changes. What are the first things I need to do with my leadership to start moving in this better direction?
I think really the first part of leadership is setting the vision of where you want to go. Because if you're just aimlessly driving your boat or your car or whatever, you don't know where you're going to end up. And so it really is sitting down with the team, whether it's, a group of nurse educators or a campus, a university, or if it's, a team in the physician's office or at the hospital. It really is, what are the outcomes that we want? Where do we want to be? And then together deciding what is the vehicle, what is the engine that is going to get us to where we want to go. And then checking back in and getting that buy-in from the team to say, I'm not sure that's going to work, or, okay, let's talk this out. What do you think would be helpful? And I think just being open to that and understanding the way to move the needle, it's got to be different if it's not where you want it to be right now.
I really do love that you say that buy-in is huge. I mean, Dan and I, we've worked with some organizations where like, even if the plan isn't perfect, but the buy-in is high, the executional performance is way better. Therefore the result is better versus having a super perfect plan, but the team they're not bought in. They just kind of half-ass it. Going over to the operation side of it is, so you said, you work with the team, have a roadmap, look at what your North Star is. One thing that you said too, offline was hiring experts to augment your skill, right? So can you expand on that? That if that you're that doctor, say you're that business owner, and you're looking to elevate, and you're like, man, I feel like I'm missing some gaps here. What should I do?
Yeah, that's a great question because I'll just use myself as a case study.
Yeah.
Being a nurse and an employee for all these years and then starting my business about 18 months ago, I realized because I'm older, been around the block a couple times.
Nonsense. No way. Born in 1995, I say. Yep. No.
But only understanding the experience that I've had and knowing if I really want to help people in a meaningful way and not just my community, but I want to help, if I want to save 1 million lives, if I'm going to do that, what is the vehicle and how am I going to do this? And realizing I know nothing about business or entrepreneurship. I didn't even know what a CTA was, call to action for your audience, or a VSL, a video sales letter, or so I joined mastermind groups. I hired business coaches. I took online training. I did everything that I could to educate myself because I didn't know what I didn't know.
Mm-hmm.
And I helped the most people in hiring people that had already walked my path or knew how that I could prevent falling in the manholes because I don't have time or money to keep doing that. Right.
Yeah.
So yeah, that's valuable.
Yeah, I think that's a fair point. It's having some humility, but not overcoming those insecurities, so to speak, and that ego that comes along with it. That I think prevents a lot of people from just being able to admit, hey, I don't know. Like you just said, it's not even a matter. I don't know what I don't know. It's just I'm not the expert in all things, and I do find that. And Antonio and I have both experienced this where in medicine, obviously, a ton of us are extremely educated, but I think there's that ignorance that comes along with, hey, I'm really good here, so that must mean I'm really good here too. Like I'm a great provider, so I'll be an amazing entrepreneur as well. And it's hard to admit, hey, yeah, right? It's like, okay, I don't know everything, but and that goes along with what you said at the beginning, which is even in medicine, we don't know everything. So being able to admit, hey, I need somebody else to do this for me. What's been, when you talk about hiring somebody specifically from a business coach perspective, what's been like the one or two biggest takeaways for you, or the biggest, holy crap, I didn't know that, and it was like a big aha moment for you?
One of the things that just comes to mind, when I was promoted from dean to campus president at the university, they hired a business coach and we got to meet once a month which I wish I could do it every week because it was so valuable. But I made a huge mistake, an associate dean of general. On paper, he looked good, and during the interview, he looked good. But within a week or two, I was like, and so in that business coaching that we had right after that, I don't remember the name of the book, but the 3 takeaways for me when you're looking someone to your team, are they hungry? Are they humble? Are people smart? Because they could have all the skill set and years of experience or whatever, but if they don't have all 3 of those components, they're likely not going to be a good fit for your team. Because it kind of speaks for itself, right? If they're humble, then they're going to be willing to learn and work with you and say, or I was wrong. I'm stuck by that, and that's 7 years ago, and it's really served me well.
Well, one thing that you mentioned, so we kind of sent over a questionnaire, and one of the things that stuck out to me, especially around culture, because I can imagine a situation like that can impact culture, where now you and your colleagues are looking at each other like, what is going on? We should be further ahead. You mentioned that culture is driven from the top, and it's always from the top. What's been your experience with that, and why do you say that?
Gosh, this brings up why I put what we talked about buy-in too. So when I was, losing my earbuds here. When I was promoted to the campus president in Virginia, I came into a team who were hungry for leadership. And we sat down, we read, a chapter of a leadership book we picked together. I think the first one we did was Simon Sinek's What's Your Why? Or
Start with Why.
Anyway,
yeah.
Start with Why. That's it.
Great book.
Couldn't think of it. Yeah, it was wonderful. And we really built a phenomenal team. And then I went to another organization that was about 4 times as big, and I used the same strategies of bringing the team together. They weren't interested. They didn't want change because that situation was their previous leader had, let's say,
Oh,
taken advantage of the COVID situation, and everybody got to work from home, and we were teaching students online, and the cheating was going up, and our pass rates for boards were going down. And when I was hired, they said, you need to get everybody back on campus. Well, I didn't get buy-in. I don't know how I could have, but I didn't succeed. I mean, yes, we got everybody back on campus, and we got the NCLEX pass rates up. We went from 66% to over 83%. And that was amazing. So I accomplished those things, but the team was not happy. And I just figured my skill set that I had used before would work, and it didn't. So that was really disappointing for me as a leader. So I probably needed to approach it from a more emotional intelligence and understanding the team. But I went from a team of about 40-ish to over 300.
mm-hmm.
I'd be curious, outside of the size of the team, looking back, because it's a very relevant story. Obviously a great person, great leader. I'm like listening to you, and I'm just like, why would somebody not, want to make those changes? But then it brings into the fact of just the personalities of the employees. But outside of just the staff itself, go look back. What would you say are the major differences between the two groups that you could say, well, this is why I had success with this group, but maybe not with this one? And do I need to change my approach, or do I need to maybe change the group?
Yeah, that was tough. I think part of the mistake I made was bringing in those tools and not getting their buy-in to say, what do you guys think? Because I saw that it worked, and I figured and assumed it would, and we were under a time crunch. But yeah, big lessons learned there. And it's hard to work with a team that big with so many various personalities. A lot of them just wanted to do their job and not really invested in the outcomes, the student outcomes in this case, which was really disappointing for me. I thought, we're in the compassion industry here, people.
Yeah, that's kind of one of the things that Dan and I have encountered before, where there's organizations that we're trying to work with, and there is strong buy-in with some individuals, and there's very low buy-in with other individuals. So it's like someone's super gung-ho, and then on the other side of the building, people that are just like rah, rah, rah. And we start to recognize, like, this person may not be a good fit. Like there's that saying, right? That the people that got you here won't take you there. Have you ever had those types of conversations with organizations where you're just getting to know their staff, getting to know them, even with what you're mentioning now, where you're like, we're really trying to make some changes, and there are a few bad apples here that are rather cancerous to the organization, and we're needing to snuff them out?
I think sometimes it's hard for leaders to accept that. But if you've got the evidence, they may say, well, that employee's been here for 12 years, or, I hired her. She's not that bad. She's just gone through some tough times or whatever. But you used a really good word there. That word cancer just proliferates if we don't shut it down. And that toxicity grows if we don't, give those employees an opportunity to grow and to get on board, because the bus is leaving. Or you may want to be successful somewhere else, because it's not, as this organization is growing, get on board, or, check out.
Dr. Julie, what's your strategy with that? Because you mentioned, like, hey, the bus is moving. Is it like a one strike policy? Does it vary? Does it depend on the position? Does it depend on tenure? Walk us through kind of the chances, or kind of that adoption rate timeline that's needed for a person to be like, we're doing these changes. We have 3 weeks to get you on board, or something's going to go down.
Yeah, I think the approach that's worked and been helpful for me is we have, let's just say, a faculty meeting or a team meeting, wherever you are. And we talk about the vision of the company, and what does that look like? And here's an assessment. Let's be honest, where are we now? So there's a gap from where we are to where we want to be. And then we talk about what's it going to take to get there. And so the group meeting is the first introduction, I guess, of where are we and where do we want to go and what's it going to take to get there. And, it's kind of interesting how they do self-select out, but that comes with follow through from mid-level leaders, for example, that will say, you haven't been reading your emails, you have been missing from these important meetings, or this is the repercussions of here's what's happening when you're not fully engaged in your job. And so documentation is huge. If you're working in an organization that has HR, I mean, that's going to be a requirement to, help someone out the door if they're not a good fit. But it's going to take, the coaching to say, this is what happened. Here's where I would like to see this go. How can I assist you in making sure you get to your meetings or read your email or implement the strategy we've talked about as a team? And that's when they get uncomfortable, when they're held accountable. Either they do it or they step off.
That's a great point you just finished up there, that the people who really want to be part of it and grow and develop are the ones that are going to say, I welcome the feedback. I want to be held accountable. Whereas the other people who get defensive, it starts giving you some insight into, okay, maybe this isn't the kind of person that's going to help us, get to the next level. And you mentioned something a little bit earlier too that was really fascinating, which is, it's like, come on, people, we're in the compassion business, and and it makes total sense. There's this expectation that we have of anybody who's really in healthcare, that they have this certain mindset of how we're going to go towards the people that we're trying to serve. And it's not reality. So it's almost that we have these expectations and they trip us up. And I know that was, for me when I was starting out, I think it took me about 10 years to just finally accept, not everybody's in this to help the patient. And it's just, some of us are super dedicated and some of us are not. But then we have the same concept with employees or people that we're working with. It's just, I have this expectation of you and then it falls short. So I feel like what you more or less described there were just getting your standards and values in order and being able to articulate that.
For sure. That is really the essence of painting your strategy of your organization. What does it look like? Where do we want to go? Is exactly what that's going to require, for your team.
What does it mean when we talk about having a patient-centric medical facility? What does that actually mean? Because I know for some people they have their interpretation, but for you, how does that look and sound like?
There's one of my patient safety heroes. He's just amazing. Dr. Don Berwick. He was the past president of the IHI, the Institute for Healthcare Improvement. And what he said, I was listening to a webinar, he said, we as healthcare providers need to ask to the patient, not what's the matter with you, but what matters to you. Because not everybody's going to choose the same option for the plan of care. And I think we really have to start with the understanding that everyone is a human being with a different, blueprint of where they came from and where they want to go. And we have to honor that. Our goal as healthcare providers is to assist them to live the best life possible. And that may be for some going on dialysis, as an example, or some saying, no, I don't want to live that way. I'm not going to do that. I'll just, peace out. So I think it's really important to have those heart-to-heart conversations. And the way I look at it is every patient is someone's mother, father, brother, sister. I think we need to get the heart back into healthcare and say, that could be my mom I'm talking to or treating. And just looking at from a humble perspective of what would I want? And maybe it's not the same as what they want.
Yeah, that's definitely from the perspective from the healthcare provider down to the patient, and kind of flipping it. One of the things that you mentioned was, empowering families. And so they're going into facilities and they're going into the clinics and they're going to see their doctor, that they're more educated, they're more savvy. They, so what does that look like kind of on that end? Like, what do you wish more people knew or things that they can dive into? So when they do meet their medical provider, that they can have a better heart-to-heart, like a better understanding of what's going on.
I think the way I see the shift that has to happen in healthcare is, again, that partnership and that bridge. So the more that a patient and their family can learn about the medications they're on, the disease process, and what they want out of life, really, because that's got to be an important piece of it too. And then having those conversations of understanding yourself, because a doctor is going to treat, 1,000 patients and they all are going to be different. But establishing that trust and respect, because that's a patient right, to be treated with dignity and to have the information they need. And the healthcare team just needs to respect this patient wants this or that patient wants that. So the more that you can learn, the more that you can become educated. But I think in understanding that that's your right too, we have such a culture of hierarchy that we just say, well, the doctor knows best, but that's not like it used to be.
I was actually just going to ask you, like my follow-up question was to that is, how much of it needs to be a perspective change that we're not looking at these doctors as these pure authoritarian figures, like they have the ultimate authority. Because you mentioned earlier, it's more of a collaborative process. It's a partnership, you said. So how much of that is just, you got to change your perspective of how you look at these people that are actually serving you?
A lot of patients and families are scared to speak up because they say, well, if I the nurse or doctor too many questions, they're going to give my dad poor care, or if I stand up and say, no, something is wrong, you need to go get the charge nurse or you need to get the house supervisor, that after I leave, after visiting hours, that they're not going to answer my dad's call bell or something like that, which is crazy. But we really have to establish that the patient's voice matters, the voice of the consumer, because again, they are the ones that know their body the best or know their family member the best. And there's what I call the 3 Ps: be present. And I tell patients and their families, try to be there during shift change or when the doctor comes in, if you're in the hospital. Be polite, but you also have to be present in your heart. You have to assume good intent, but we can't just leave it there. So then be polite and then be persistent. So if you're not getting resolution for what you really believe is a problem with your family member, you've got to escalate it, but there's still a way to do that politely. But don't give up.
And this is one of the communication gaps that it seems like this is probably one of the biggest one. It's the doctors listening the right way, taking time, having patience, being present. But then it's also the patience of standing your ground, understanding your body a little bit better, having your voice, finding your voice, understand that it's a partnership. It's not just, you just shut up and you just do whatever they tell you. How do we solve this kind of patient safety problem generally from where you sit?
I think it's a global issue. It's not one hospital. It's not one healthcare center. It's really just not even a country. It's pretty much all over the world. The UK and Canada have patient safety statistics that are similar to ours. But, the root cause analysis, if it's done properly, when a patient error occurs, then it will always, you can't say always, but 99.9% of the time go back to a systems error. Let's take for an example, do you guys recall the Redonda Vought case out of Vanderbilt Hospital several years ago?
No, could you expand on that, please?
Yeah, Redonda Vought was a nurse that was working in the critical care area. She was floated down to radiology, which she was not familiar with that area. There was a patient that came through the ER. I want to say she was about 75, fell and hit her head. So she had a little bit of change in consciousness, so she needed to go get a CAT scan. Well, the patient said to Redonda, those things, I'm claustrophobic. I don't think I can go into that tube, that tunnel. And so Redonda got an order for Versed, anti-anxiety medication, from the doctor, injected it into the patient. Patient came out of the CAT scan 30 minutes later dead. So what they realized after investigation is that she had not given the patient Versed. She gave the patient vecuronium, which is a paralyzing agent, a paralytic. And that's why she died. I mean, they did revive her for a couple of days, but she was anoxic or without oxygen for so long that she was brain dead. And so Vanderbilt fired the nurse. They settled with the family and they put on the death certificate natural causes. And so finally, an anonymous tip came in and said, here's what really happened. And so then this investigation revealed the systems error that Redonda, I mean, there was multiple, but Redonda was orienting a new nurse. She was working in an area that she wasn't familiar with. The hospital did not have a policy for monitoring patients that are given even Versed, which was, not, it was ordered, but not given. But maybe that would have stopped, hey, if they were monitoring during the CAT scan, hey, her heart rate's too high or too low or breathing rate, and stop the process and, stop the scan and went and saw what the problem was. But also the automatic dispensing cabinet where the medications came from were not working properly throughout the whole hospital. And the nurses just hit the override button just to get their medications. And so that was a common practice. But where this error led to this patient's death was the override said paralyzing agent caution. And she hit override and ignored it. And there was probably about 6 to 10, again, different areas where this could have stopped. And so that's what I mean by systems errors. And if we get to the whole global problem, or even let's go national or whatever, it's transparency. So because it was swept under the rug for a couple of years till it came out with this investigation, nobody's going to learn from that problem. No other hospital, no other nurse is going to learn from the mistake.
Gosh, that seems like just a simple Dan, like an audit would just alleviate like some of these system errors or these just.
Yeah, it's like how often does a company actually go through like what is the process that we undergo to get the patient something as simple as medication? How does the order come in? How does it get checked? What happens if the override alert comes on? What do we do? So it's definitely some easy checks and balances that could be instilled if somebody just takes, periodic, even, I feel like even if it was like yearly, which still isn't that great, but just every year we go through everything to make sure everything's in tip top shape. And then I'm curious, outside of just the processes and the systems, I know one of the major issues, more so not even just in healthcare, but most, I think, prevalent with nursing, is massive shortages, and then a lot of that secondarily being to burnout, right? So then you have decreased staff, which for that person who's rushing around, they're saying, well, Julie, I got all these other patients I have to treat, and they have to have their meds on time and whatnot. So when we're talking about instilling the right systems to help overcome maybe our lack of staffing, even from the standpoint of better patient care, how do you're in it? How do you see us maybe solving that problem, so to speak, of having shortages when it comes to staff and the burnout? And then how does that maybe tie into just improving some systems along the way as well?
Yeah, it's interesting. I just did a TikTok last night, I believe it was, on when a nurse is caring for more than 4 to 5 patients. So some of the hospitals in rural areas or what is the word? Critical access hospitals.
Yeah.
A lot of those are in low income places. The nurse turnover is 50% higher in those places. So you're always going to have a new nurse usually in those. But if a nurse has up to 8 patients, every patient higher than the safe workload of 5, the patient deaths increase by 7% every patient over that. So let's just say she's caring for 8 patients versus 5. That's a 21% increase in patient death rates
For all 8.
In those staffing situations. So staffing is really, the shortages have been going on for a very long time, but they really contribute to burnout, like you said, because the majority of nurses work a full-time job is 3 12 hours, at least in the acute care settings. But a lot of them will work overtime because, number one, they may need the money. I worked with some Filipino nurses that were working 2 full-time jobs, so 6 days a week, and sending money back to their land, which bless their hearts for doing that. But man, they got tired, and it's not just the physical work of 12 hours on your feet. It is the psychological, moral distress, ethical dilemmas that go on in healthcare nowadays too, that are so draining. So nurses aren't staying in the profession any longer like they used to. You don't have that many lifers, or not that many retire. You know, an average of 3 years and they're out.
Holy crap.
Yeah.
So what do we see? You're saying 3 years, which is, you know, you're seeing that even in medical doctors too. It's the amount of people that they graduate, and then within 3 to 5 years, this wasn't for me. So we can kind of imagine what that leads to. But just to paint a picture, not even just in a hospital setting, but just in healthcare in general, for the person who's a little, maybe they just don't know, what do you see that actually leading to?
Well, the big picture, it feels like the healthcare system is crumbling. You know, when we don't have seasoned professionals. And one of the other things that I read recently in the news is the cap on student loans for professions is not going to cover medical school.
Yeah.
So that's going to impact the doctors. I know we're already super short on radiologists. It's scary. I'll just be honest.
What do you anticipate happening? You know, 5 years time, 10 years time, 15 years time. Like if you had your own crystal ball and you're like, I expect, based off where we're at, this is what healthcare is going to look like. What's your take?
My optimism is that the healthcare system, or the hospital systems, will see, we cut staffing because that's the easiest place. It's the largest part of a P&L statement, right, is the nursing staff. And that's where they cut first. But when I look at healthcare overall, the average hospital spends 13 to 15% of their annual operating cost on patient harm. So that is failing to recognize a patient is becoming unstable and now they're in the ICU, but the DRG codes won't pay for it, or ICD codes won't pay for it because that's not what they were admitted for. And so we have this cycle, whether it's malpractice, you know, that we pay out millions of dollars sometimes. And so if medical harm, let's just take the average hospital. I was looking at one, in fact, in Austin, and they had an $88 million annual operating income in 2024. If we look at even 10%, not even the full 13 to 15% that they spent on patient harm, that's almost $9 million. Mm-hmm. If you hire more nurses and you train them correctly, your patient harm is going to fall. You know, the rates are going to improve drastically. And you've just saved yourself some money that paid for staffing. But the majority of them are so short-sighted, they can't see the payoff of hiring more nurses and increasing the education.
I love that. I want to actually go back to the case study that you mentioned a little bit before, because this is where it feels like there's some of that overlap where you're bringing in just staff, their bodies. But if the systems themselves are not being refined and the infrastructure is not being elevated and things are not being polished, could that exacerbate a problem?
Oh, for sure. So when you look at, you know, EHRs, when they came onto the scene, were great. They were really developed for billing purposes, and they did improve. I mean, years ago.
Sorry to interrupt. Just for the audience, what's EHRs?
Oh, sorry about that. Electronic health records.
Okay.
So years ago, when I was trying to read a doctor's handwriting to figure out what medication he scribbled, you know, we had to either try to figure it out or call them. Yeah. And now it's electronic, right? But with that came complexities that made the job even harder. Meaning, I mean, most of the nurses now spend, and I think doctors too, 40 to 50% of their time documenting or in the medical health record, trying to, you know, find things, document things, connect the dots or whatever. But, you know, one of the issues that have come up that's not been addressed yet is the alerts. So a physician will order something, the pharmacist or the nurse may, or even the doctor themselves may get hundreds of alerts, and there's no way they can read them all. So they just dismiss them. And then, you know, we are missing the ones that are critical are missed because every one of them pretty much is like, I can't read all that. I'm just going to dismiss it. I think I know what I'm doing. I've given this med 100 times or whatever, but that's where mistakes happen. So that's an example of systems errors that we need to fix.
And you know, it's funny. It's interesting that you mentioned that, because I've seen some stats on just what you said, you know, electronic health records, which is, think when they started coming out, everybody's like, all right, cool, no more paper, and we're finally moving into the right decade, so to speak. And now everybody's like, these EHRs are terrible, and it's making it harder for us. So it's almost, and it's something that you kind of mentioned earlier. You invest a ton of money into a lot of these systems, right? And then you get, maybe if you're the kind of leader who gets some feedback from the staff, and the majority are saying, appreciate it, but this is a horrible system, and it's making our job harder, and it's affecting us and the patients. There's never usually, okay, let's get rid of it and let's work on a new system. It's what we got. It's I spent $1 million or however much money. I mean, even in a smaller clinic, you can spend up to $250,000, if not more. And you're like, well, we made the investment, so now you guys have to deal with it. So it's this aspect too of getting the systems, but then making sure, are they actually helping us be better at what we're supposed to be doing here?
Yeah, that's a really good point. I was listening to a webinar with some doctors the other day on a patient safety webinar, and one of them was the anesthesiologist, and he had a pediatric case, and he wrote in his area of the chart the orders for the IV. Well, when the nurse got the patient in the PICU, the pediatric ICU, she didn't see that order, and another physician had written a different order. Long story short, the wrong solution put this kid in a coma. And again, it was diabetic and, all sorts of things that were going on with the surgery. But it's having things in different parts of the chart that aren't syncing and talking to each other that can create, problems like this. But I gave a talk in San Diego a couple months ago, and it was the voice of the consumer, patient's voice, et cetera. But what it was also is adding AI into the mix.
Yeah.
Which a lot of people are scared of AI, but if it's programmed, it can augment the human experience. And one of the ideas that they're now doing, but I love this, is the sepsis alerts. Instead of waiting for the nurse to notice the lab values or tying together the data points of, the increased temperature, the increased heart rate, the white blood cells are up, and now the lactic acid levels are up. This alert can go across and say, hey, go check this patient. They're fitting the sepsis criteria, sometimes hours before, it would have been connected before. So I think there's a lot of things that are going to improve with the electronic health records when we're augmented to, lighten some of the burden on the human.
Yeah. I'm familiar with, so Dan and I have a relationship with some managers, even with Kaiser. And they're integrating, AI components to this, because that's kind of one of the biggest things that they were having challenges with, is just even the messages that were in queue. And so they trained this AI, and it basically did that. Like, they had, I think, a couple million that were kind of unanswered within a certain time frame, and then those were completely finished. That would have taken weeks and weeks and weeks. That was done in a day. And like amazing. Now, and so there's some really, really cool stuff there. I'm wondering with you, I know we kind of asked you the question about like the old crystal ball thing. What do you feel like is the future of healthcare, kind of from a positive perspective? Like, if you were to go into an organization and say, like, you guys are running this ship with the utmost gold standard, describe how that looks like from your perspective.
I love that, because I am optimistic. I do think we can create processes and change that will benefit the human experience as a patient in the hospital. But I think transparency, I think communication, optimizing AI with our workflows. If we can get, and I know they're working on this, but where the nurse isn't spending, or the doctor's spending so much time in documentation, that allows more time to be with the patient. From the doctor's perspective, they can listen and, I didn't realize that before, put that together with the big picture. Or nurses, right now they say, I don't have time to do an assessment. And I'm just like, what is the foundation of how you're caring for this patient for the day? You've got to have a baseline, listen to their lungs, listen to their heart. What's their Glasgow Coma Scale, their neurological state of being. And, if they're skipping that, then that's why this cycle of patient harm keeps occurring. So I think we all need to be open to what can we do within the realm of our capacities, and be open to how do we work together to solve this problem.
Yeah.
Can I add a couple? I want to see what your thoughts are on this, especially with what you described a little bit earlier, is making sure that this new healthcare business, the gold standard, also allocate some resources to having like a CTO, to having like an operations team in place, that they're constantly monitoring systems and protocols and make sure they're efficient and not doing something one time years ago. And then here we are 15 years later doing the same thing and it's just outdated and it's not working. How do you feel about, having things like that in place where there's coders and engineers with a hospital?
I love it because it takes a team, right? Yeah. For example, there was an article written not too long ago that said the majority of hospitals look at very few of their patient harm events because a lot of it is not mandatory for reporting. And so they don't really understand and know what the issues are that they can fix to prevent it from happening again. So again, it's that transparency, it's the desire to have better outcomes. And I think utilizing everybody on the team, it's essential.
So it feels like there are things that happen in healthcare that are not really out for public consumption. Like it's you that, you being in the space, Dan and I and others, where it's like we're monitoring some of these things, but it feels like, everyday families, they're not 100% aware of some of the shortcomings or the misgivings or the fuck ups that happen in the space sometimes, where if they knew more of that, do you feel like that would kind of quote unquote empower them to be far more assertive with their own doctor?
I do. So I have two thoughts on that. One is that when hospitals settle a malpractice suit with a family for egregious patient harm or death, 80% of them have the family sign an NDA as part of the problem. So it doesn't get out there and people don't hear about it for obvious reasons, right? But the other part of that is I think that when the patients and the families can start being proactive, and I'll give you one thing. I don't know if I told you this before, Dan, but there's a website called hospitalsafetygrade.org. It's a nonprofit data from the hospitals every 6 months, and it rates. Go onto that site, put in your zip code, and it will rate the hospitals in your area A through F, just like your high school papers or college paper grades. And you can see the 22 categories of patient safety. So, for instance, one of the main categories is surgery. And you can look in there and see how do patients at this hospital fare with post-op blood clots, post-op respiratory problems, a couple others in there. But that way you're empowered, and you don't need a medical degree to read it because it's red, yellow, green. In this category for infections, for example, Clostridium difficile, they're a red. MRSA, they're a red. It's like, okay, well, that's a problem. But I would never go to a D or F rated hospital. Your chances of patient harm occurring at a D rated hospital are 91% higher. And so again, it's like flaws in how that hospital system is run. And so this is a way that patients and families can empower themselves by saying, I'm going to have surgery. Dr. Jones is going to do it at this hospital. This is a C-rated hospital, and I'm looking at the surgical outcomes, and I see that they really do poorly on postoperative blood clots. That empowers you as a patient to say, Dr. Jones, I see that there's really poor outcomes post-surgery with blood clots. So how are we going to work together to prevent that I get a blood clot?
Yeah, imagine that. And I really love that, because then the other aspect too is, you're really essentially describing is just kind of sweeping crap under the rug, right? It's like, let's hide the bad news and the bad publicity instead of, dialing down and fixing the actual issue. But then we have this critical issue in the especially in the U.S., but a lot of misinformation and disinformation, and there's more, bad news with regards to how people feel about healthcare. Yeah, I mean, like you said, you're on TikTok, and it's just, all right, one good video that you're posting versus how many, BS, don't trust doctors, and they're all out for the money, X, Y, and Z. And then you would think hospitals would say, well, let's get ahead of it and just try to fix it because it's actually contributing to that. But, when we look at the amount of misinformation being put out there and, what we can actually do, and I really honor any medical professional like yourself who's out there and actually posting and, educating people. What else do you think just individual medical provider systems can do to maybe get ahead of some of that? Just to put a better spin, so to speak, on what the good stuff that we're doing in healthcare looks like.
I think it's building trust. That's the first thing with the consumer. I think most people are unaware of all the harm events that could occur. And it's not like I want to raise this, red flag to scare people. But if we're not aware, then we're not going to take any steps to become informed and educated and empowered, right? So I think advocating in the way, pardon me, for empowering the patient, really truly listening, and providing resources for the patients are a really good step to build that rapport and trust. There's going to come a point where we have to earn it. Right now, most healthcare providers are respected. And the majority, nobody ever wants to harm a patient. The majority of the healthcare providers, doctors, nurses, and everybody in between really do want to help.
Yeah.
And so we have to give them the tools to say, this is some options for you. This is what you could do here.
Tell us a little bit about, so kind of going back to tools and things that people can use to address patient harm in healthcare. You, I understand, have an app coming out. Can you tell us a little bit about that?
Yeah. Yeah. So when I wrote my book a couple of years ago, I broke it down into chapters where I thought it would be really helpful for patients and their families to learn about patient rights, to pick a hospital, like we just talked about. Here's what to know about, high risk medications. And, that again is one of the reasons I started my TikTok channel last year, was to inform and educate and just, hey, were you aware? And a lot of the posts I do are public service announcements or whatever, like this is what's going on in healthcare or whatever. But I just think this is the next step in my journey to be able to get this information out there to people that need it. When you're sitting in the ICU, you're not going to flip through a book. But if you're like, hey, I remember this app that will teach me what normal vital signs are. What does it mean when my dad's heart rate is high? What does it mean when I think he's got an infection? Where do I go first? Do I go to the doctor, the urgent care, or the hospital? To just make it a succinct place where people can, learn things. I've got courses that I've built that I'm putting in there that can, how do you communicate? How do you speak up when you're scared, or those types of things? So I'm really excited about it.
That sounds phenomenal. And I respect it, because there's a lot of good in healthcare, but there's also a lot of people who we don't do much. There's a lot of people complaining about a lot of these issues, but they're not taking a lot of action on it. And you're doing the opposite, which I can really just honor and respect. And I think I said to you the other day, I would love to just go on talking to you for another 2 or 3 hours probably, but
yeah, same. I got so many more questions.
It's such
We
good
can do part 2.
Yeah,
yes.
so I think you're gonna definitely have to have you back, but I really appreciate you coming on. This was honestly phenomenal. There's definitely, like I said, so much more we can be discussing, but really appreciate you just opening our eyes, sort of listening to this, getting a little bit of that education, as you said, not scaring the hell out of them, just showing them what's reality and how to just start taking some care for yourself. Dr. Julie, really appreciate you having on. It's been awesome.
Yeah, thank you so much.
Thank you.
And if someone is watching and they want to connect with you, what's the best way for someone to connect with you?
So my website and my socials are Dr. Julie Siemers, so drjuliesiemers.com. But can I leave your audience one more tip?
Yes.
So this one I shared in my TEDx talk, which I think is powerful and easy to learn and remember, is the cuss words. When you're frightened and you're concerned, and you don't know what words to use. So CUS stands for concerned, uncomfortable, scared, or there's a safety issue. And so anytime that you're scared, use that word and say, I'm really scared here. My father's never acted like this. Something's wrong. And it hopefully will get the attention of the healthcare team to pay attention.
I love that. This was absolutely phenomenal. Thank you so much, Dr.
Yes.
Julie. And we're going to have to do a part 2 and expand on a lot of the stuff that we talked about today. Thank you so much, you guys.
Thank you.
Appreciate it.